Hi class, welcome to the last lecture of health assessment. So today we're going to talk about the neurologic assessment, which is arguably one of the most important assessments we'll perform because it evaluates the function of both the central and peripheral nervous systems, and even subtle neurologic changes can indicate a rapidly developing emergency. So recognizing abnormal findings early is really essential. Now, the nervous system controls virtually every body system, so during this assessment, we are evaluating the patient's ability to think, communicate, move, feel sensations, maintain balance, and respond appropriately to their environment. And one of the biggest concepts to remember is that neurologic assessments establish a baseline. So once you know what is normal for your patient, you can quickly recognize deterioration during subsequent assessments. So unlike a complete neurologic exam performed by a neurologist, bedside nurses will typically perform a focused neurologic assessment that emphasizes early recognition of change. So depending on the patient's condition, we may assess them very briefly neurologically, doing neuro checks every few hours after a stroke, or doing a more comprehensive neurologic assessment during a routine physical. Here are those learning objectives today. So before we perform our neurologic assessment, it's helpful to review the major structures of the central nervous system, or the CNS. So the CNS consists of the brain and spinal cord, and it's responsible for receiving, processing, and responding to information. Then we have the neurons, which are the basic functional unit of the nervous system, and each neuron has a cell body, which contains the nucleus. There are dendrites, which receive information from other cells, and finally the axon, which carries signals away from the cell. So neurons communicate through electrical and chemical signals to control body functions. Then we have the cerebrum, which is the largest part of the brain, and it's responsible for conscious thought, sensation, movement, memory, and language. We have the frontal lobe, which controls voluntary movement, personality, judgment, and speech production, also known as Broca's area. Then we have the parietal lobe, which processes touch, pain, temperature, and spatial awareness. The temporal lobe, which is involved in hearing and memory, and also language comprehension, which is known as Wernicke's area. And then finally, the occipital lobe, which is responsible for vision. And we have deeper structures of the brain, including the basal ganglia, which helps regulate smooth, coordinated movement, the thalamus, which acts as a relay station for sensory information, the hypothalamus, which regulates body temperature, hunger, thirst hormones, and autonomic nervous system, the limbic system, which plays a major role in emotions, motivation, and memory. And then we also have the brainstem, which connects the brain to the spinal cord and controls many vital functions necessary for life. The midbrain, this helps with eye movements and reflexes. The pons helps regulate breathing and sleep and serves as communication pathway. The medulla, which controls heart rate, blood pressure, and respiration. The reticular formation, which helps regulate alertness, consciousness, and the sleep-wake cycle. Cerebellum, which coordinates balance, posture, muscle tone, and smooth, purposeful movements. And so damage to the cerebellum often results in poor coordination and unsteady gait. And then we also have protective structures. So the brain is protected by several structures, including the skull, which provides physical protection. Then the meninges, which are 3 layers of connective tissue that surround the brain and spinal cord, and the ventricles, which produce and circulate cerebrospinal fluid. And cerebrospinal fluid cushions the brain and spinal cord and helps remove waste and provides nutrients. So this should essentially be a review from anatomy and physiology. So now that we've discussed the central nervous system, let's look at the peripheral nervous system, or the PNS. And while the central nervous system serves as the body's control center, the peripheral nervous system acts as the communication network that connects the brain and spinal cord to every other part of the body. So think of this as if the brain is the hospital administrator making decisions, the peripheral nervous system are the phone lines carrying messages to and from every department. So the peripheral nervous system allows the brain to receive sensory information from the environment and send motor commands to muscles and organs. So we have the spinal cord, which is a major communication pathway between the brain and the body, and it begins at the base of the brainstem and it extends through the vertebral column to approximately the level of the first or second lumbar vertebra. So the spinal cord performs two major functions. It carries sensory information from the body to the brain, and it carries motor commands from the brain to the muscles. It also serves as a center for many reflexes that occur without conscious thought. For example, if you accidentally touch a hot stove, sensory nerves immediately transmit the pain signal to the spinal cord, and before your brain even processes what happened, the spinal cord initiates a reflex that causes you to pull your hand away. So this rapid response actually helps prevent further injury. And so damage to the spinal cord can interrupt communication between the brain and the body. The level of injury really determines what functions are affected. For example, a cervical spinal cord injury may impair movement and sensation in all four extremities, whereas a lumbar injury affects only the lower extremities. Then we have the cranial nerves. The peripheral nervous system also includes the 12 pairs of cranial nerves. And unlike spinal nerves, cranial nerves emerge directly from the brain or brainstem rather than the spinal cord. So each cranial nerve has a specific function. Some are responsible for sensation, some control muscle movement, and others perform both sensory and motor functions. As bedside nurses, we typically perform a focused cranial nerve assessment rather than testing all 12 nerves in every patient. So we routinely assess pupils, facial symmetry, speech, swallowing, tongue movement, and shoulder strength because these are going to provide valuable information about neurologic function, and they're particularly important in patients with suspected stroke. So later in today's lecture, we'll discuss some practical ways to assess each cranial nerve and identify findings that should raise concern. Then we have spinal nerves. The peripheral nervous system also contains 31 pairs of spinal nerves, which branch off the spinal cord and innervate the entire body. And so these nerves are considered mixed nerves, meaning they contain both sensory fibers, which bring information to the central nervous system, and motor fibers, which carry commands from the central nervous system to muscles. So the spinal nerves are divided into regions. We have 8 cervical, 12 thoracic, 5 lumbar, and 5 sacral, and 1 coccygeal nerve. So notice that there's 8 cervical nerves, but only 7 cervical vertebrae. This is actually a really common NCLEX question because the cervical nerves exit above their corresponding vertebrae, with the exception of the 8th cervical nerve. So each spinal nerve supplies a specific area of skin called a dermatome and specific groups of muscles called myotomes. So understanding dermatomes helps clinicians localize neurologic injury. For example, if a patient reports numbness along the thumb and lateral forearm, this may suggest involvement of the C6 nerve root. So many neurologic disorders involve the peripheral nervous system rather than the brain itself. Things like peripheral neuropathy, commonly seen in patients with diabetes, results in numbness, tingling, burning pain, and decreased protective sensation in the feet. Guillain-Barré syndrome, this is an autoimmune disorder that causes rapidly ascending muscle weakness, and it can progress to respiratory failure. Bell's palsy, this affects the facial nerve and results in unilateral facial weakness. Radiculopathy, which is often caused by a herniated disc compressing a spinal nerve, which leads to pain, numbness, or weakness along that affected dermatome. So recognizing whether symptoms originate from the central nervous system or the peripheral nervous system is going to help guide further assessment and treatment. The autonomic nervous system, or the ANS, it regulates involuntary body functions, meaning functions that occur without any conscious thought. So unlike the somatic nervous system, which controls voluntary skeletal muscle movement, the autonomic nervous system controls cardiac muscle, smooth muscle, glands, blood vessels, internal organs. It's constantly working to maintain homeostasis, so it's adjusting body functions based on the body's needs. Things like heart rate, blood pressure, respiratory rate, digestion, pupillary size. There are two divisions of the autonomic nervous system that work together to maintain balance. So we have the sympathetic nervous system, which prepares the body to respond to stress or danger. And you'll often hear this called the fight or flight response. And then we also have the parasympathetic nervous system, which has the opposite effect. It promotes the body's rest and digest activities. So when you're sitting down after dinner watching television, that's when your parasympathetic nervous system is working its hardest. Let's see. Then the autonomic nervous system communicates using chemical messengers called neurotransmitters. The two major neurotransmitters you'll encounter, epinephrine and norepinephrine. These are primarily active, activate the sympathetic nervous system, so increasing heart rate, blood pressure, cardiac contractility, respiratory rate, blood glucose. And you'll hear these discussed frequently in pharmacology because many medications either mimic or block those effects. Acetylcholine, this is the primary neurotransmitter of the parasympathetic nervous system. It slows the heart, stimulates digestion, promotes glandular secretions, and supports normal resting body functions. Reflexes. Now let's shift to that. Reflexes are another important component of the neurologic assessment. A reflex is an automatic involuntary response to a stimulus. And they occur very quickly because they do not require conscious thought. They allow the body to protect itself from injury and maintain posture and muscle tone. Reflex arc. So every reflex follows the same basic pathway called the reflex arc. There are 5 components. A receptor detects the stimulus. A sensory neuron carries the signal to the spinal cord processes the information, a motor neuron carries the response away, an effector muscle or gland produces the response. So notice that the brain does not have to initiate the movement. The brain becomes aware of the stimulus after the reflex has already occurred. And this explains, again, why you withdraw your hand from a hot stove before even consciously realizing it. There are several categories of reflexes. So we have deep tendon reflexes, and these are the reflexes most commonly assessed during a neurologic exam, including the biceps, triceps, brachioradialis, patellar, Achilles. And these help evaluate the integrity of the peripheral nerves, spinal cord, and upper motor neuron pathways. Then we have superficial reflexes, which occur when the skin is stimulated. Examples include plantar reflex, abdominal reflex. So one important example is the Babinski reflex. In adults, stroking the sole of the foot could cause the toes to curl downward. An upward movement of the great toe with a fanning of the other toes, that's called a positive Babinski sign, and it may indicate upper motor neuron lesion. But in infants, this response is considered normal because the nervous system is still developing. Then we have visceral reflexes, which regulate internal organ function. So pupillary constriction in response to light, bladder emptying, blood pressure regulation, GI motility. Many of these occur automatically through the autonomic nervous system. And then finally, neonatal reflexes. So infants are born with several primitive reflexes that will disappear as the nervous system matures. So things like the moral reflex, which is the sucking, rooting, palmar grasp, stepping reflex. So any persistence of these reflexes beyond the expected developmental age can actually indicate neurologic dysfunction. Back to older adults. So one of the most important things to understand is the difference between normal neurologic aging and abnormal neurologic changes. So many of our patients, especially in med-surg, are older adults. So while some neurologic changes are expected with aging, others should never be dismissed as just getting older. So our goal is to recognize what is considered a normal age-related change and identify findings that require further evaluation. things like structural brain changes. So as people age, the brain undergoes gradual structural changes, and one of the most common changes is the loss of neurons and a decrease in the number of synaptic connections between nerve cells. So although the brain can compensate for many of these changes, communication between neurons becomes slightly less efficient. And blood flow through the brain also decreases modestly with age, and nerve impulse conduction slows. So these normal physiologic changes may contribute to slower processing speed, but they don't significantly impair a healthy older adult's ability to function independently. It's important to remember that healthy aging is not resulting in sudden confusion, significant memory loss, or loss of independence. Those are abnormal. Reduction in brain volume. So beginning around middle adulthood, there is a gradual decrease in overall brain volume, particularly in the frontal cortex and hippocampus. The frontal lobe is responsible, again, for executive functioning, planning, and decision making. So while the hippocampus plays a critical role in learning and memory. So although brain volume decreases with age, many older adults continue to have excellent cognitive function. Reduction in cognitive abilities. Many older adults notice subtle changes in cognition. Normal age-related cognition changes include slower processing of new information, taking longer to recall names or words, mild decreases in multitasking ability, longer reaction times, and needing additional time to learn new technology or unfamiliar tasks. But long-term memory, vocabulary, and accumulated knowledge, those are generally preserved. One of the most common mistakes in healthcare is assuming that confusion is a normal part of aging, which it is not. Acute confusion is more likely to represent delirium, which may be caused by infection, dehydration, medications, metabolic disturbances, or hypoxia, and that requires prompt assessment. Increased risk for poor balance, postural hypotension, falls, and injury. So neurologic aging also affects balance and mobility. And several factors contribute to this fall risk, including slower nerve conduction, decreased muscle strength, reduced proprioception, changes in vision, vestibular dysfunction, delayed reaction times. So that's going to contribute to poor balance, postural hypotension, falls, and injury. Always assessing for that. Reduced light touch and pain sensation. So normal aging also affects sensory perception. Older adults often experience decreased sensitivity to light touch, pain, temperature, vibration, and position sense. And because sensation is diminished, injuries may go unnoticed. So for example, an older adult with diabetes and peripheral neuropathy may not realize they have developed a foot ulcer until it becomes infected. Likewise, burns from heating pads or hot bath water, they may occur because temperature sensation is impaired. So always comparing sensation bilaterally, considering that the patient has reduced sensation, may also increase their risk for injury. And then increased size of the ventricles. As brain tissue gradually decreases, the fluid-filled ventricles within the brain naturally enlarge. This enlargement is considered a normal finding in healthy aging, and it reflects the loss of surrounding brain tissue. However, significant ventricular enlargement may also occur in conditions such as normal pressure hydrocephalus, which can present with gait disturbance, urinary incontinence, cognitive impairment. So unlike many dementias, normal pressure hydrocephalus is sometimes reversible with treatment, making early recognition of that important. As nurses, it's important to recognize that neurologic diseases do not affect all populations equally. However, it's equally important to understand why these disparities exist. So differences in neurologic outcomes are often influenced by a combination of factors, including genetics, prevalence of chronic diseases such as hypertension and diabetes, socioeconomic factors, access to preventative health care, environmental exposures, health literacy, and structural barriers to care. So recognizing these disparities is going to help us provide equitable care while avoiding assumptions or stereotypes about individual patients. And so I have some information on more cultural variations and health disparities in this slide. One of the most important responsibilities is recognizing, again, when neurologic findings represent an emergency. So many neurologic conditions develop gradually, whereas others can deteriorate within minutes. Because the brain is highly dependent on oxygen and blood flow, delayed recognition can result in permanent neurologic damage. So this slide is highlighting just assessment findings that should immediately capture your attention and provide prompt, rapid intervention. A helpful phrase to remember is any sudden neurologic change is an emergency until proven otherwise. So significant changes in neurologic status. So when performing a neurologic assessment, always compare your findings to the patient's baseline and ask yourself, is this new? Has this changed since my last assessment? Is it getting worse? Trending assessment findings over time rather than relying on a single assessment is really important. Any acute change in mental status, this is one of the earliest signs of neurologic deterioration. Any sudden change in mental status, like new confusion, disorientation, agitation, difficulty following commands, sudden lethargy, new memory impairment, and personality changes. So a patient who was alert and oriented this morning but is now confused should never be dismissed as just tired or, oh, they're just, off. I don't know. Just do something about that. Because potential causes could include stroke, hypoglycemia, hypoxia, infection or sepsis, medication effects, electrolyte abnormalities, increased intracranial pressure, always assessing airway breathing, vital signs, blood glucose, oxygen saturation, and the time that the symptoms began. Any unexplained changes in level of consciousness, this is going to be the most sensitive indicator of neurologic function. So patients progressing from alert to lethargic or obtunded to comatose. Seizure activity, so any new seizure activity requires prompt assessment. During a seizure, our priorities are going to include protecting the patient from injury, maintaining airway, timing the seizure, observing the characteristics of the seizure. We're avoiding any restraint. We're never placing anything in the patient's mouth. And after the seizure ends, we're assessing the neurologic status, airway, oxygenation, and possible causes. Another finding requiring immediate attention is abnormal posturing, which often indicates severe brain injury. There are two classic postures: decorticate posturing, which is flexion of the arms towards the chest, like they're grabbing the spinal cord, with extension of the legs. This suggests injury above the brainstem. And then we have decerebrate posturing, which is extension and internal rotation of the arms with plantar flexion. It suggests more severe damage involving the brainstem. It's generally associated with a poorer prognosis. But both findings require immediate provider notification and rapid evaluation. Changes in pupil size or reactivity. So the pupils provide valuable information about that brainstem function, right? So normal pupils are equal, round, reactive to light, and accommodating. So concerning findings would include unequal pupils, dilated, pinpoint, sluggish reaction, non-reactive. So these findings may indicate increased intracranial pressure, brain herniation, intracranial bleeding, cranial nerve 3 compression, sometimes medication side effects or drug intoxication. Remember, we're comparing both pupils and documenting. Progressing weakness or paralysis. Any new weakness, especially if it develops suddenly, requires immediate assessment. Asking our patients to smile, raise both arms, squeeze their hands, push and pull with their feet, comparing both sides, because any unilateral weakness can suggest stroke, intracranial hemorrhage, brain tumor, or spinal cord injury. And then changes in sensation. Sensory deficits may include numbness, tingling, loss of light, touch, loss of pain sensation, inability to identify limb position, sudden unilateral sensory loss often accompanies a stroke. So, whereas progressive bilateral numbness or ascending weakness, it may suggest disorders such as that Guillain-Barré syndrome. But again, always comparing sensation on both sides of the body. And then any significant changes in vital signs. Neurologic emergencies often produce changes in vital signs. Sometimes hypertension with a widening pulse pressure, bradycardia, irregular respiration. So together, it might indicate intracranial pressure, possible brain herniation. Sometimes other concerning findings include severe hypertension during an acute stroke, and on the opposite, hypotension, which reduces cerebral perfusion. Sometimes fever can increase cerebral metabolic demand and cause seizures. So interpreting vital signs. In many clinical situations, you won't have time to perform a complete neuro exam. So if a patient suddenly develops neurologic symptoms, your priority is going to perform a focused neurological assessment. So to quickly determine whether the patient is deteriorating or whether immediate intervention is needed. So this abbreviated assessment is commonly performed in emergency departments, ICUs, stroke units, postoperative settings, and whenever a patient experiences an acute change in neurologic status. So think of this as your rapid neuro check. It should only take a few minutes, but it provides a lot of great information about brain function. And the first and most important assessment is the patient's level of consciousness, because this is one of the earliest indicators of neurologic deterioration. So begin by asking yourself, is this patient awake? Do they respond appropriately? Can they follow commands? Has their level of consciousness changed since the last admission or assessment? For patients with altered consciousness, we commonly use the Glasgow Coma Scale, or GCS, to provide an objective measurement. So the GCS evaluates 3 components: eye opening, which is 4 points, and we observe how the patient opens their eyes. If they open them spontaneously, that's a 4. If they open their eyes to verbal command, that's a 3. If they open their eyes only to painful stimuli, that's a 2. And then no eye opening is a 1. And then we look at verbal response, assessing orientation and communication, which is 5 points. So the higher the score, the better outcome. The lower the score, the worse the outcome for the Glasgow Coma Scale. So take a look at the Glasgow Coma Scale for what it measures and how many points are allocated for each. And then we assess pupils. So remember the acronym PERLA. Pupils equal round, reactive to light, and accommodation. And we're assessing the size, equality, shape, direct light response. Any concerning findings would be fixed pupils, sluggish response, unequal pupils, dilated or pinpoint. And then we look at extremity strength. So motor strength is one of the fastest ways to screen for stroke or spinal cord injury. We'll want to ask our patient to raise both arms, hold them out in front, squeeze both of your hands, do the push and pull with both feet, comparing the right and left sides. And we're looking for any weakness, adrift, paralysis, or asymmetry, like one-sided weakness. That's always concerning for a stroke. Then we're looking at facial asymmetry, which provides us information about cranial nerve 7 function for possible stroke. So we're asking our patients to smile, show their teeth, puff out their cheeks, raise both eyebrows, close their eyes tightly, and we're observing for facial droop, any flattening of the nasolabial fold, unequal eyebrow movement, and difficulty closing one eye. Sensation. If the patient's awake and able to communicate, we're assessing sensation by lightly touching both sides of the body and asking if it feels the same on both sides, so the arms, the legs, and the face. Patients may report numbness, tingling, burning, or decreased sensation. We're always comparing side to side. If consciousness is impaired, Additional brainstem reflexes may be assessed, and these are going to help us again determine whether important brainstem structures are still functioning. And then finally, vital signs. Always looking at vital signs for abnormalities. So before we begin the physical exam, it's important to obtain a thorough health history, as you know by now. So our subjective assessment is going to help us identify patients who may be at increased risk for neurologic disorders, and it provides us valuable context for interpreting our physical assessment findings. So many neurologic conditions develop gradually, and subtle symptoms reported by the patient may be early indicators that something is wrong. So asking focused questions allows us to establish a baseline, also identify risk factors, and guide our objective assessment. So first thing is assessment of risk factors. A health history should focus on identifying any factors that increase the patient's risk for neurologic disease, while also exploring any current neurologic symptoms. Common symptoms that you might want to ask about: headaches, dizziness or vertigo, syncope or fainting, weakness, numbness or tingling, tremors, difficulty walking, any memory changes, speech difficulties, any vision changes or seizures. And so we want to know the onset, duration, severity, frequency, and progression of the symptoms, which are going to provide us important clues to the underlying cause. Biographical or general demographic information. So age is one of the strongest risk factors for many neurologic disorders. Stroke risk increases with age. Parkinson's disease typically develops after age 60, along with Alzheimer's disease, which becomes more common in older adults. Whereas some disorders like multiple sclerosis, this often presents in younger adults between the age of 20 and 40. Occupation may also provide important information. So patients who work in construction or manufacturing, agriculture, or military settings may have a history of repetitive head trauma or chemical exposures, toxin exposure. So we want to ask about that, as well as any participation in contact sports or activities with a history of repeated concussions. Past medical history. Many chronic medical conditions significantly increase the risk of neurologic disease. Some important conditions to ask about include hypertension, diabetes, hyperlipidemia, atrial fibrillation, coronary artery disease, any previous stroke or TIA, which is transient ischemic attack, seizure disorders, migraines, multiple sclerosis, Parkinson's disease, dementia, traumatic brain injury or spinal cord injury. We also want to ask about previous surgeries involving the brain, spine, or carotid arteries. Lifestyle and personal habits definitely have a significant impact on neurologic health. So we want to ask about things like smoking, which we know accelerates atherosclerosis and can substantially increase the risk of stroke. Alcohol use, because excessive alcohol consumption can contribute to peripheral neuropathy, cognitive impairment, falls, nutritional deficiencies, and withdrawal seizures. Recreational drug use, so substances like cocaine, methamphetamines, and opioids can increase the risk of stroke, seizures, altered mental status, and, of course, overdose. Physical activity, so regular exercise reduces the risk of stroke and supports cognitive health. So education on that is important, as well as diet, because poor nutrition and vitamin deficiencies, particularly vitamin B12 deficiency, can contribute to neuropathy and cognitive changes. And then sleep, asking about quality of sleep. Untreated sleep apnea can increase the risk of hypertension, stroke, and cognitive impairment. Then moving on to medications, we're always performing a thorough medication review. Many medications can affect neurologic function. Things like sedatives, benzodiazepines, opioids, anticonvulsants, antidepressants, antipsychotics, muscle relaxants. So we want to ask about any prescription medications, over-the-counter medications, herbal supplements, and recent medication changes. Family history. Some neurologic disorders have a strong genetic component, so we want to ask whether close relatives have been diagnosed with stroke, aneurysms, Alzheimer's disease, Parkinson's, Huntington's, multiple sclerosis, epilepsy, migraine headaches, peripheral neuropathies, things like that. Although family history does not guarantee that the patient will develop a condition, it may increase their overall risk and then influence screening recommendations for that person. And again, as nurses, our role extends beyond assessment. We're also educators, and so every patient encounter is an opportunity to promote neurologic health and prevent injury and help patients manage chronic neurologic disorders. Many neuro diseases cannot be completely prevented, but we can often reduce risk, delay progression, or improve quality of life through patient education. So, as you know, the teaching you provide should always be individualized based on the patient's age, risk factors, their health literacy, diagnosis, and support systems. So stroke prevention, stroke is one of the leading causes of long-term disability, but many strokes are preventable by addressing modifiable risk factors. So education should focus on controlling the conditions that contribute to stroke, things like maintaining a normal blood pressure, managing diabetes, lowering cholesterol, treating atrial fibrillation, quitting smoking, limiting alcohol intake, and exercising regularly, as well as eating a heart-healthy diet that's low in saturated fat and sodium. Recognizing a stroke. This is an equally important part of stroke prevention. So teaching the families the B FAST acronym, B for balance, so any sudden loss of balance or coordination. E is for eyes, so sudden loss of vision or double vision. F is for face, which is facial drooping. A, arms, so weakness or numbness in one arm. S for speech, so slurred speech or difficulty speaking. And then T for time, which call 911 immediately and emphasize to the patient that stroke treatments are highly time dependent. So never drive themselves to the hospital, never wait to see if symptoms improve. Injury prevention, so protecting the brain and spinal cord from injury. It's another important aspect of neurologic health. So strategies appropriate for the patient's age and lifestyle. So always wearing a seatbelt while in a vehicle, wearing helmets during bicycling, skiing, snowboarding, things like horseback riding or motorcycles, contact sports. So that's important for head protection. And then preventing falls, removing any trip hazards, using handrails, improving the lighting, and wearing supportive footwear. Remember to avoid alcohol or drug use before driving or operating machinery, using assistive devices such as canes or walkers when needed. And then for older adults, just, important fall prevention education is particularly important because even seemingly minor falls can result in traumatic brain injury or subdural hematomas, especially our patients on blood thinners. Chronic neurologic conditions, so many disorders listed here are chronic progressive diseases that require long-term management rather than cure. So helping patients understand their diagnosis, manage symptoms, and maintain the highest possible level of independence for those. So when we're collecting a neurologic health history, it's important to ask about common symptoms that may indicate dysfunction of the brain, spinal cord, peripheral nerves, or cranial nerves. And these symptoms often help guide the rest of our assessment and help us determine whether the problem is acute, chronic, localized, or generalized. So as you ask about each symptom, remember the old CARTS framework. So common symptoms like headache or other pain. Headache is one of the most common neurologic complaints, but not all headaches are the same. So we're asking where the pain is located, when did it start, was the onset sudden or gradual, how would you describe the pain, is this your usual headache, have you experienced headaches like this before, what other symptoms have occurred with the headaches. So many headaches are primary headaches, such as tension headaches or migraines, but certain headaches characteristics should immediately raise concern, like a patient saying this is the worst headache of my life, or like a sudden thunderclap headache. Those require more immediate evaluation because they may indicate subarachnoid hemorrhage. Any headaches accompanied by fever, neck stiffness, altered mental status, we're thinking about meningitis. Localized weakness, we're asking our patients whether weakness affects one arm, one leg, one side of the face, or one side of the body. There are many, probing questions that we can ask our patients about that, along with generalized weakness, which involves the entire body rather than one specific area. Sometimes possible causes of this could be infection, dehydration, electrolyte imbalances, anemia, a number of things. But also some neurologic disorders, such as Guillain-Barré syndrome, also begin with generalized weakness that progresses over time. So, we are diving in and asking more specific questions about all of these common symptoms. And these are just additional neurologic symptoms that should be explored during the health history. Many of these involve higher cortical function or the cranial nerves and can help localize where neurologic problems may be occurring. So collecting subjective data on all of these things, asking our probing questions. And now that we've completed the health history, we'll move on to the objective assessment or the physical exam of the neurologic system. So one thing students often notice is that neuro assessments can seem intimidating because there are many components. But the key is really to just be systematic and perform the assessment in the same order every time. Unlike some body systems where the assessment is relatively straightforward, the neuro assessment evaluates several different functions simultaneously. So things like mental status, cranial nerve function, motor function, sensory function, coordination, balance, and reflexes. And each part provides information about a different area of the nervous system, which helps us identify where a neurologic problem may be occurring. So fortunately, you don't need a lot of specialized equipment to perform a neuro assessment. Things like a pen light or flashlight, great tool used very frequently to assess pupillary size, even direct or consensual light reflexes like accommodation if appropriate. And remember, when we're assessing pupils, we want to remember to document the size, equality, shape, reactivity to light. Tongue blade, this is useful when assessing the mouth and certain cranial nerves that can be used to inspect the oral cavity, observe palate elevation, assess cranial nerve 10, the vagus, which helps us evaluate swallowing, so observing the gag reflex when appropriate. Remember that the gag reflex is not routinely tested on every patient because it can be uncomfortable and may increase aspiration risk. Cotton swab, this is commonly used for sensory testing. It allows us to assess light touch sensation, facial sensation, corneal reflex when indicated, protective sensation in selected patients. Patients should close their eyes during sensory testing so they respond only to what they feel rather than what they see. And we're always comparing the right and left sides of the body. Some optional equipment, things like a tuning fork, may be useful to assess vibration sensation, position sense, hearing. They're actually used less frequently during routine bedside nursing assessments, though. So unless there is a concern for sensory loss or hearing impairment, we're probably not going to use a tuning fork. A reflex hammer, this is used to assess deep tendon reflexes. So commonly used for the biceps, triceps, brachioradialis, patellar, Achilles. And remember that reflexes help evaluate the integrity of both the peripheral and central nervous systems. So now we're ready to begin the comprehensive neuro exam. So while there are many components to the neuro assessment, remember that each one builds on the previous step. So we start by assessing the patient's overall neurologic status before moving into more specific tests of cranial nerves, motor function, sensation, coordination, and reflexes. So as you perform the assessment, continue asking yourself, is this finding normal? Is it symmetrical? Has it changed from the patient's baseline? Does this finding help localize where the neuro problem might be? And so we start with the level of consciousness. This is one of the most sensitive indicators of neurofunction because it Any changes in consciousness often occur before other neurologic deficits become more obvious. So begin by observing our patient as soon as we enter the room with our eyes. We're asking ourselves, are they awake? Are they alert? Do they make eye contact? Are they responding appropriately? Can they follow commands? So for a routine health assessment, we're simply documenting whether the patient is alert and oriented. If the patient appears altered, we're determining orientation to person, place, time, and situation. So that if the patient has any altered level of consciousness, you might want to perform a Glasgow Coma Scale assessment, which we discussed earlier. And remember, even subtle changes in level of consciousness deserve a lot of attention because they may indicate worsening neurologic status. Next, we're evaluating the patient's cognitive abilities. This assessment tells us how well the cerebral cortex is functioning. So during normal conversation, we're assessing the patient can answer questions appropriately, recall recent and remote information, follow simple and complex commands. They're maintaining attention, they're thinking logically, they're demonstrating appropriate judgment. So examples of these questions is, what brought you to the hospital today? So they might tell you a story. Is that accurate? Can you tell me today's date? Who is the current president? Or another culturally appropriate orientation question. Can you tell me what you would do if you smelled smoke in your house? So these questions are going to help us evaluate memory, orientation, judgment, abstract thinking, and attention. Communication. So as you're talking to the patient, you're already assessing communication. We're listening carefully for clear articulation, appropriate word choice, fluency, comprehension, voice quality, and we're observing whether speech is clear, slurred, slowed, rapid, hesitant. And we're also determining whether the patient understands your questions, can follow directions, responds appropriately. And so in this phase of our assessment, we're remembering the difference between aphasia, so a language disorder where the patient has difficulty understanding or producing language. Dysarthria, so this is a motor speech disorder. The patient knows what they want to say, but weakness of the speech muscles causes slurred speech. This can be common in a lot of chronic neurologic disorders. Next, we're assessing the pupils. We're using our pen light to evaluate this. Again, size, shape, equality, reactivity to light, and accommodation. And then finally, we're observing the patient for any involuntary movements. And we're doing this while the patient is sitting, talking, holding their arms out, walking, or looking for any tremors, muscle twitching, fasciculations, any tics, chorea, dystonia, any restlessness. So certain movement patterns are associated with specific neurologic disorders. For example, a resting tremor is a characteristic of Parkinson's disease. Now we're going to work through the 12 cranial nerves, which originate from the brain and brainstem. These nerves control many of the functions we assess every day, including smell, vision, eye movements, facial sensation, hearing, swallowing, and tongue movement. So a full cranial nerve assessment is often performed during a comprehensive neuro exam, usually by a neurologist or a specialized nurse who has been trained in cranial nerve assessment. But as bedside nurses, we're typically performing our focused assessment, especially for patients with suspected stroke or neurologic changes. So as you're going through these, remember that some cranial nerves are sensory, some are motor, some perform both sensory and motor functions. So cranial nerve 1, olfactory, this is sensory and function, sense of smell. This nerve is not routinely assessed during a standard nursing assessment, but if indicated, have the patient close one nostril and identify a familiar odor such as coffee or peppermint. We're trying to avoid irritating substances like alcohol because they stimulate pain receptors rather than smell receptors. So the patient should be able to identify familiar smells in each nostril. Cranial nerve 2, optic, This is sensory and functional. This is responsible for vision, visual fields, carrying information from the retina to the brain. So we're assessing this with the visual acuity using a Snellen chart, if appropriate, peripheral vision by confrontation, and inspecting the optic disc with the ophthalmoscope during a complete eye exam. Cranial nerve 3, oculomotor. This is also motor and function. So it's controlling most eye movements, eyelid elevation, pupillary constriction, and accommodation. So we're asking our patients to follow our finger while you assess extraocular movements. And we're checking eyelid position, pupil size, direct and consensual light reflexes. Cranial nerve 4 is the trochlear. This is motor and functional. It controls movement of the superior oblique muscle, which allows the eye to move downward and inward. We're assessing this nerve during extraocular movement testing, so having the patient, again, follow our finger downward towards the nose. It should be smooth downward eye movement, no double vision. Cranial nerve 5, this is the trigeminal, both sensory and motor function. It provides facial sensation, muscles of chewing. So we're assessing for sensation with light touch to the forehead, cheeks, and jaw, and we're asking if both sides feel the same. For the motor aspect, we're asking our patient to clench their teeth, open and close the jaw, and we're palpating the temporal and masseter muscles. Cranial nerve 6, the abducens. This is motor and function. It moves the eye laterally, so this is also included with the extraocular eye movement testing. So having the patients follow our finger from side to side. They should move their eyes laterally without any difficulty. Cranial nerve 7, this is a facial, both sensory and motor function. This controls our facial expressions, taste on the anterior 2/3 of the tongue, tear production, and salivation. So we're asking our patient to raise their eyebrows, close their eyes tightly, smile, show their teeth, and puff out their cheeks. Taste is rarely assessed, again, during routine nursing examinations, but patients with strokes affecting this cranial nerve might say that they are tasting things a little bit differently than normal. Cranial nerve 8, vestibular cochlear, sensory and functional, responsible for hearing and balance. So we're assessing hearing by, our conversation with the patient. Also, you can do the whisper test where you whisper in their ear. We can assess balance by observing their gait. So normal findings would be that they're hearing appropriately, they have good balance, and no dizziness. Cranial nerve 9, this is a glossopharyngeal, both sensory and motor function. It's responsible for swallowing, taste on the posterior 1/3 of the tongue, and gag reflex. So we're assessing by observing the patient swallowing. Again, gag reflex is generally not tested routinely unless clinically indicated, because it can be uncomfortable and elicit the pain response. But normal findings should be that the patient swallows easily, they have clear speech, and no choking. Cranial nerve 10, this is the vagus nerve, both sensory and motor function, so it controls swallowing, voice, palate elevation, parasympathetic functions of thoracic and abdominal organs. So we're assessing this by asking the patients to say ah, and we're observing the soft palate rises equally. The uvula remains midline. We're listening to voice quality and observing swallowing. So normal findings would be that the uvula is midline, we have a symmetric palate elevation, and a clear voice. Cranial nerve 11 is the accessory. This is motor and functional. It controls the sternocleidomastoid mastoid muscles, the trapezius muscles as well. And we're assessing this by asking our patients to shrug their shoulders against resistance and turn their head against your hand for strength. So that it should be strong, equal shoulder shrug, and strong head rotation. And then finally, cranial nerve 12, this is the hypoglossal, which affects motor and functional, controls tongue movement. So we're asking our patients to stick out their tongue, move it side to side, push it into each cheek while we apply resistance. So the tongue should remain midline, strong tongue strength, and smooth movement. So now that we've assessed mental status, cranial nerves will move into evaluating motor function, cerebellar function, and sensory. And these assessments tell us how well the brain, spinal cord, peripheral nerves, and muscles are working together. So as with the rest of the neuro exam, we're always comparing the right and left sides of the body. Symmetry is one of the most important aspects of the neurologic assessment. So starting with motor function, which evaluates the patient's ability to produce voluntary movement and helps determine whether the motor pathways of the brain, spinal cord, peripheral nerves, and muscles are intact. So we're assessing 3 major components: muscle bulk, muscle tone, and muscle strength. So muscle bulks, we're going to start by simply observing the patient's muscles. And we're observing for symmetry, size, and shape. And the muscles of both sides of the body should appear relatively equal. We're looking for any muscle atrophy, which is a decrease in muscle size. We're also observing for fasciculations, which are small involuntary muscle twitches, and it may indicate lower motor neuron disease. Next, we're assessing muscle tone. We're passively moving the patient's arms and legs through their range of motion while the patient relaxes. Normal muscle tone provides slight resistance to passive movement. Abnormal findings would be hypotonia or decreased muscle tone, where the limbs feel really floppy, or hypertonia, which is increased resistance to movement. Muscle strength, so we're asking our patients to push and pull against our hands. Common muscle groups include upper extremities with hand grasps, arm flexion, arm extension, and the lower extremities with hip flexion, knee extension, foot dorsiflexion, foot plantar flexion. Again, we're comparing both sides. And strength is typically graded on a 0 to 5 scale. So 5 out of 5 would be normal, 4 out of 5 slight weakness, 3 out of 5 they have movement against gravity only. 2 out of 5 they have movement only when gravity is eliminated. And then 1 out of 5 where muscle contraction without movement. And then 0 out of 5 with no muscle contraction whatsoever. So documenting 0 out of 5. And then one simple bedside assessment of upper extremity weakness is the pronator drift test. So we're asking our patients to extend both arms forward, turning the palms upward, closing their eyes, and holding the position for about 20 to 30 seconds. Normal would be that the arms remain steady, and abnormal would be we see one arm drifting down or the palm turns inward or pronates. A pronator drift is a sensitive indicator of subtle upper motor neuron weakness, and it's commonly performed during stroke assessments. Now looking at the cerebellum, which is responsible for coordinating voluntary movement, maintaining posture, and preserving balance. So a patient with cerebellar dysfunction may have normal muscle strength, but poor coordination. So something we do is the finger to nose test. We're asking our patients to touch their nose, then touch our finger, and we want to repeat that several times, observing whether the movement is smooth and accurate. Difficulty performing this task may indicate cerebellar dysfunction. And then the heel to shin test, we're having our patients slide one heel down the opposite shin from knee to ankle. Normal movement would be smooth and controlled. Any jerky or inaccurate movement suggests cerebellar dysfunction. Rapid alternating movements, so asking the patient to rapidly flip their hands over repeatedly on their thighs or tap the palm and back of the hand alternatively. Any difficulty performing rapid alternating movement is called dysdiadochokinesia. Wow, butchered that. But this is another commonly associated with cerebellar disease. Ataxia, this refers to uncoordinated movement, while our patients may demonstrate a wide-based gait, any staggering or difficulty turning, and poor balance, and it commonly results, again, from cerebellar disease. We also can see it in alcohol intoxication, sometimes multiple sclerosis, stroke, or vestibular disorders. So we're observing the patient's gait whenever possible. And then finally, we're assessing sensation, whether information from the skin is successfully reaching the brain. So having the patient close their eyes during testing, always comparing right to left and going from distal versus proximal. Again, light touch, sometimes using a cotton swab, and then superficial pain sensation using a disposable neuro tip by alternating the sharp and dull ends. You'll see neurologists do that. And the final component of a comprehensive neuro assessment is evaluating deep tendon reflexes, which provide information about the integrity of peripheral nerves, spinal cord, and upper motor neuron pathways. So while you as a nurse may not perform a complete reflex exam on every patient or any patient in a medical surgical setting, understanding how reflexes are graded is going to help you interpret neurologic findings and communicate them accurately. Why do we test reflexes? So deep tendon reflexes evaluate whether the reflex arc is intact. Remember the components of a reflex arc. A sensory receptor detects the stimulus, the sensory nerve carries the impulse to the spinal cord processes the information, a motor nerve carries the response back, and the muscle contracts. So if any part of that pathway is disrupted, the reflex may become diminished or absent. So on the other hand, if the brain is no longer properly regulating the spinal cord, sometimes as occurs with upper motor neuron lesions, the reflexes may become really exaggerated. Common deep tendon reflexes include the biceps reflex, which is C5 and C6, brachioradialis reflex, again C5 and C6, triceps reflex, C7 and C8, patellar reflex L2 to L4, and Achilles reflex, which is S1 to S2. And you don't have to remember the spinal levels for your routine bedside assessments, but it's really helpful to know that each reflex corresponds to a different spinal nerve level. How to test a reflex. So when testing reflexes, we're positioning the muscle so it's relaxed. We're supporting the extremity and striking the tendon, not the muscle, with the broad end of the reflex hammer. And we're using a quick wrist motion rather than swinging our entire arm. Again, always comparing right and left sides. And symmetry is often more important than the absolute reflex grade. So looking at this grading scale, I think it's pretty self-explanatory. So now that we've completed our neurologic assessment, the next step is using those findings again to make sound clinical decisions. While diagnostic testing can help confirm a diagnosis, our assessment is often what first identifies something wrong with the neurologic system. So when we're identifying abnormal neurologic findings, we're asking ourselves, is this an expected finding or does this require immediate action? We're also inquiring about interprofessional collaboration. Depending on the patient's deficits, you may work with providers, physical therapy, occupational therapy, speech language pathology. So, including them in your communication of the patient, coming up with an individualized plan of care. Throughout the patient's care, we're continuing to evaluate whether our interventions are improving outcomes or whether the patient's neurologic status is changing and requires further intervention. And that is it for today. I know this is a long one. The neurologic assessment is quite in depth. So I can't wait to see you for our last lab. I hope you have a great day.